So many thanks for the invitation to join you. I work as a clinical psychologist in cancer and palliative care services in Gloucestershire, and I'll run through some aspects of the psychological impact of pelvic radiation disease, touch on the literature around these, and also give some suggestions for what can help and how services can respond. The caveat is that I have no claim to being a renowned expert on psychological effects in PRD, so I've largely drawn on my clinical experience of working with patients rather than having international research status to profess, I'm afraid. But I do think there's much more we can learn and do differently in services. So, a brief sketch of just some of the psychological effects. The symptoms of PRD can range from anxiety provoking to debilitating. Some effects are given here, for example, social anxieties, worries about incontinence, which can be very isolating. Fear of recurrence is often higher. Low mood, especially as the length of time with symptoms extends. The perpetuation of grief and adjusting to losses, changes in body image, relationships and sexual functioning, sometimes guilt at surviving treatment, yet also struggling with symptoms, and decisional regret about having treatment, to name a few. And the experience of PRD can compound pre-existing difficulties as people experience pelvic investigations, surgery, and treatment often as traumatic and can develop post-traumatic stress symptoms. So that list is by no means exhaustive, and concerns will be different according to people's personal history and context, but they can also be compounded by services or professionals' responses. So the feeling of not being believed, or symptoms not being investigated, or being bounced between services, or being told nothing will help can precipitate or exacerbate concerns. So how services respond is really key. I won't read all of these out, but the perspectives here give you just a flavour of the impact of PRD symptoms psychologically. And I'm sure there are others on the conference who could give much more detailed descriptions of the extent to which PRD can really affect people's lives. In terms of prevalence, the literature largely confounds the psychological effects of surgery and other cancer treatments, but some headlines would be initially from the Cured but at What Cost document on the effects of treatment that can have. Estimates from various studies for people post-cancer treatment vary for depression, anxiety and PTSD, which are given there. But there's also evidence that alongside head and neck cancers, cancers that affect the gastrointestinal tract and pelvis have higher prevalence rates of psychological distress and also suicide rates. Some findings give anxiety and or depression as higher post-treatment in gynae and neurological cancers, with similar findings in the large CREW study, which was from Southampton, on colorectal patients with the figures there. And what's really interesting too from the CREW study is that depression and low self-efficacy pre-treatment. So self-efficacy is someone's confidence in coping, and those were as important as stage of disease for predicting quality of life and long-term recovery post-treatment. So attending to psychological variables early on can make a big difference later on. And there's also a paper there, which is from this year, specific to PRD, and which found higher levels of psychological distress related to higher symptom burden and lower quality of life. So what can help with these effects? This is the NICE model for levels of intervention that's provided the model for services for responding to psychological concerns for almost 20 years now. And essentially level 1 is all healthcare professionals. And level 2 is those with additional training and skills in working with psychological concerns, which is usually CNSs or other allied health professionals, and levels 3 and 4 are specialist psychological or mental health professionals, but it's more often simplified into universal, enhanced or specialist interventions. So I'll go through those 3 levels, but people may need different input at different times. Those levels aren't linear by any means. So thinking about universal input for healthcare professionals, early detection is key. So if we think about psychological distress on a continuum from milder concerns through to more severe mental health problems, intervening early when concerns are milder makes all the difference, as it does for other PRD effects. And that's what the CREW study would suggest with its findings on early levels of depression and confidence in coping. Alongside early detection, having potential side effects explained and professionals having the confidence to ask about the impact of longer term or late effects is paramount. So much of the skills at the universal level overlap with skilled communication, and that which might fall within the realms of patient experience work as well. So do ask a friendly or local psychologist to be involved with anything they can help with. How questions are asked makes a big difference. So questions that normalize symptoms can help. So for example, something like asking other people with similar symptoms after radiotherapy describe how it can affect their mood or body image or sex life. Has that been the case for you? Or effect questions. So asking what effect have these symptoms had? One reason people don't ask, I find, is because they don't know what to say or do next. So being aware of where to signpost onto, for example, the PRDA community, other hospital services, Macmillan Resources, Maggie's, social prescribing, or some cancer support workers might fit in this role at this level too. And also this CHIPS model here is just a simple framework to help with one option of how to respond when people mention psychological concerns. So asking who've you confided in, who've you told, what other conversations have they had, and what's helped in the past, how have people coped in the past, the I for what you can do, what I can do, and then discuss together with the patient what they can do and summarize your next steps. So that's a helpful acronym. In terms of universal input for patients, those with milder concerns, some suggestions here of what might help. Again, PRDA obviously is a great first port of call, and there are manifold benefits of being connected to others with similar experiences alongside advice. Other self-management resources are the Macmillan online fatigue resource called Restore. Breathworks is probably the go-to site for mindfulness for health. Not that it's a panacea, but some people find mindfulness helpful. Apps like Headspace can help, or Sleepio is the app for sleeping difficulties that is evidence-based and endorsed by the NHS. There's the Sherwood Forest Hospital's Cancer Psychology website with a link there, which is a great site and a good overview of ways of approaching difficulties. And the rest mentioned here are books. So there's one on practical coping, one on long-term effects. It's written by a counselling psychologist affected by cancer. Living with the Enemy is written by a clinical psychologist with over 30 years experience in cancer care. There's one on living with pain, and one on ACT, acceptance and commitment therapy, which is emerging in research that it's psychological flexibility that helps people cope or manage better, not just using one strategy, but flexing how you cope with the challenges someone faces. So ACT would be one of the top evidence-based approaches to look into, because that focuses on developing psychological flexibility. Enhanced input is usually given by CNSs, clinical nurse specialists, and allied health professionals, and most should have access to what's known as level 2 psychological skills training. So they're well placed for conversations and first line interventions for mild to moderate problems. And they should also ideally be receiving ongoing clinical supervision from level 4 specialists to maintain those skills. Unfortunately, psychological concerns don't lend themselves to algorithms for referral pathways, because what's appropriate is usually context dependent. But some IAPT services, so that's improving access to psychological therapies services, offer level 2 to 3 services, and some have long-term conditions arms, and that might be more used to dealing with people with physical health related concerns. But the kind of caveats given there as well in terms of being for milder concerns. There's also Relate, and pain management services quite often have a strong psychological component to them. In Gloucestershire as well, we're privileged to have a late effects radiographer, Samantha Bostock. So she does much of the level 2 work that's PRD specific, as I know other late effects services do as well. And here's one example of one way to equip and enhance level 2 skills for PRD. So in the early days of Sam's post, we developed a workshop series for AHPs likely to be working with patients with late effects. And they were on topics that Sam thought were most relevant. So we included topics such as behaviour change, working with pain and fatigue, body image, psychosexual concerns, responding to traumatic events that you can see there. And so all those AHPs now have ongoing group clinical discussion as a way to keep those skills going. And in terms of specialist input, if we're looking at upwards of 20% of patients with PRD needing specialist interventions, then many, though not all, cancer or oncology services have cancer psychology services or psycho-oncology services and those are usually to refer to for moderate to more severe concerns, and they can be particularly important for assessing the interaction between physical and psychological symptoms in PRD, and for more complex interventions, for example, for PTSD, and also for consultation, advice, training, and supervision for level 2 practitioners. The criteria and routes to accessing those services may vary locally, and the go-to policy document that's the most thorough is the Macmillan TCST commissioning guidance there, alongside, as mentioned, in numerous pieces of NICE guidance. So to round up, what can really make a difference in preventing psychological distress and intervening early is how services are designed and delivered. So attention to psychological factors needs to be like words through a stick of rock. They need to be considered throughout the pathway, or from prehab to rehab. So pre-treatment, adapting and adjusting well to the impact of treatment means patients having clear and realistic expectations beforehand, information communicated in a way that's understandable and retainable. For example, pelvic floor exercises and things people can do pre-treatment help to have some degree of control or agency or confidence in coping. Also giving people clear avenues and permission to raise issues post-treatment, and professionals being comfortable asking about what might be sensitive and embarrassing symptoms to patients early on upstream. Early access to all the levels of psychological input, from universal to specialist, both during and post-treatment, and with particular attention to the early identification of people with previous mental health problems or other comorbidities. This ABC model comes from a theory of motivation and is used in lots of health contexts, and it's a simple but helpful, I find, acronym. So to focus on maximising patients' choice or their autonomy, keeping connected to social support and helpful relationships in terms of belonging, and being equipped to self-manage and flag concerns in terms of competence. So ideally, pathways and access to services needs to be joined up with professionals talking to each other to have a shared understanding of how factors are interacting, rather than people bouncing between services that can erode hope. So conversations and information sharing between clinicians and patients not needing to tell their story for the 10th time, coordinating what happens when, and for that to be on an individual basis. So, for example, a referral to psychology too early can contribute to not feeling believed for one person, but for another, an early referral to psychology for someone low in mood could really help them engage with physio or with other recommendations. Trauma-informed care is an area with increasing attention in healthcare settings, and we don't have time to delve into that today, but Karen Treisman is one prominent name in that field to look up if you're interested, and she's done an online training module on trauma-informed care in medical settings. And finally, perhaps it's time to consider how psychological factors are considered in stratified care and patient-initiated follow-up. So to think how we can best serve all patients, including those that are isolated, low in mood and motivation, or other factors such as social deprivation that can make engaging with or initiating contact with services less straightforward. So there's so much scope to pursue what personalised care could really encompass. And finally, just some quick acknowledgements. Huge thanks to Samantha Bostock for her generosity in sharing her thoughts, ideas and resources, to Ray Owen, a continued inspiration and a great trainer, if you're ever able to hear him, but most of all to all the patients I've had the privilege of working with, for their generosity in sharing their experiences with me, and from whom I'll never cease to learn. Thank you.